And when we say planning, it means time. I really wonder when we do a planning without time plans. Or when we ask our orthodontic superintendent, can you do this for me? And he doesn't give me a time plan. Of course, if you do it in private sector, you need a cost plan. If you do it in university, it's not important with cost, it's not important. So plan means what, who will do it, and time frame. The design is the most important part. It's really the most important part, and is the most difficult part. Kochman said in the last meeting in Morocco that we have like 20% to 30% of us are planners. Just 20 to 30% are planners, and less than 3% are designers. What I mean by design is like a maquette. You want to buy a home, you want to buy a dress, whatever, you need to see a maquette. When you're really perfect as a dentist, you can give exact maquette, exact design about length, shape, surface texture, color, form, length, dimensions, gingiva, patella. That's lovely. You give the design for yourself or for your patient. I give it for the patient. Thank you, Dr. Muhammad, for the last presentation. Shall I give this just for shape or shape and function? I give it shape and function. So if you want to give it for shape, computer is fine for you. If you want to give it shape and function, you need a mock-up. What the American now say it is a functional prototype. You need a functional prototype. It's exact, like the end. And the patient wear it for around 6 weeks. 6 weeks to a year before he have the final. There is a special type and new types for these kind of mock-ups and prototypes, and last for more than a year, by the way. So, why do we need analysis? Simply to plan. I cannot plan without analysis. Why do I need planning? Simply to avoid problems like these. Like these. Sorry. So, if you didn't notice the lid, the lower lid, your lab doesn't see a lot, by the way. The lab doesn't see a face, doesn't see cheek, doesn't see lip, doesn't see eyes or nose. If I have something like this and looks fantastic on the cast, and when I put it in, I find it's really short. When I have a canting like this, and on the model looks fantastic, but when I put it inside, it's really bad. The treatment of something like this is not easy, by the way. A buccal corridor. Improper buccal corridor. Well, the lab couldn't get actually the reflections exactly from the cast. So we just give you a rough, high gloss surface, and it's not the same as the lower. The color degradation from incisor to cervical area and from the anterior to the posterior is improper. When I look at the cast and I find the level between the canine and central incisors nearly the same, and I consider this as, it's okay, it can pass. It's okay, it can pass, and actually cannot pass in the patient mouth, according to his smile. Improper gingival display. Improper gingival color and height. Can you see the color in the models? So why do I need to design? I need to design actually to communicate and to confirm. So I do make a communication with the client. Look, this is your original teeth, we want to move this. For that reason, we need a gingival surgery or whatever. We need to modify the surface texture for these reasons. We want to move from the midline for that reasons. So you can't just refer him to the orthodontist. That's excellent, because I move a lot actually. So you want also to communicate with the lab. Do you know that? You really want to communicate with the lab. It's not impression. You need to give him photos and he sends you photos back and my lab is really poor and he cannot understand. No, 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 no. Every time you give your lab more information, it will give you a perfect result, a more result. And I always say it. If we have a really poor labs, I don't mean poor money, poor capabilities, and you give him a lot of information, he will give you the work you really want. But give him more information. Show him where's the lip, where's the midline, what do you want to do? I will show you now how we do that. To communicate with myself, when I decided to make a plan, I want to check it if it's right or wrong, if it's good or bad. On the face, please. When I checked and want to document a present, so I want to say the patient, look here, this is very important legally, by the way. Look, you change the smile and face of the patient, really. So it's important when you finish the work, look, that was the starting point, that was the step, that was the planning, and this is the final result. We just show you the face, the smile, and your teeth before, and you signed on that, or at least You show that. This is for the documentation. For presentation, the patient, the lab, yourself, and your team can see every step you will take in the coming 6 weeks to 6 months. That's really beautiful. So, let's digitally analyze, plan, and design. And put in your mind, please, that there is no design without planning, no planning without analysis, and no analysis without guidelines. We just say that. And more important is no guidelines without good photo, right camera, right lens, right light, right angle. And it's worth it. This analysis is according to my classification. It's based on my classifications, like according to the data of the American Academy of Cosmetic Dentistry. I just made a simple classifications like Rule of 5. When you talk about classifications, you have a facial analysis, small analysis, macro analysis, micro analysis, and emphatic relations. These names and my classification is based on photos and videos. So is a facial analysis related to face photo, small analysis is smile photo, macro analysis is retracted, micro is just one tooth, emphatic relations is videos. So please follow me because I'm going to move one by one and you know how can we do it. For the facial analysis, first you need to set where's the midline. So I need to set where's the face midline. This is the most important part, and I put all the relation based on this step, so it's really important. As we know, if we want to talk about a line, so we need more than 2 points. In your opinion, what's the most important point in this? Actually, the most important point in this is the philtrum. Here, because it's really close to the smile. After the philtrum is the glabella. But the nose and menton, or nose and chin, sometimes they have some asymmetry or some deviation, so I don't put them as the first point. But if I have a third point, that will be excellent. And put in your mind that if you do this digitally, your eyes will see a lot of asymmetry or deviation that you didn't notice at the start. According mainly to the German schools and the CAD/CAM based lines, we can see there's another vertical lines just parallel to the midline. One going from the lateral ala of the nose, and that show you the intercanine width, and another one from the pupil and show you the maximum or the external wall of the buccal corridor. So you can build porcelain on the outer surface of premolars and molars till that extent. For the horizontal lines, we have interpupillary line. We used to use such line for a long time, many years, and now we don't use it anymore because we discovered more than 12% if people have whether one eye bigger than the other one, or deviation, one eye is higher in level than the other one. So we don't put our incisal plan or occlusal plan based on a line that might be deviated or might be tilted. According to McLaren in 2010, we started to use this horizontal line just perpendicular to the facial midline, and Kochman in 2012 just confirmed that and assured it. We have another lines like the commercial line. The commercial line shows you the balance. So when I'm talking, you can see if the commercial lines are balanced and or not, if I have a deviation or everything is fine. But the most important is the occlusal line or the incisal line, that I put it based on the horizontal, just parallel to the horizontal. Where I get the horizontal, the perpendicular to the facial midline. So all these relations actually is based on the facial midline. From the outer shape of the face or the lower there, I can check the shape of the central incisor and the canine. So it's really oval, rounded, square, tapered. So here I have a square tapered face, so I can predict or expect or design a central incisor which is square, and a canine which is tapered, and I do a roundation because she's a female. According to the lateral profile, I can design the lateral profile of the incisors. So I have a convex face, I can expect a convex lateral profile, and if I can expect straight or concave face, I can expect a more straight buccal surface. You can still come inside, you can set the floor here if you like, if you're just wearing jeans, I guess. For the smile analysis based on small photo, you still have a lot of things to design. You take the facial midline and the horizontal line from the face, from the facial photo, and you just apply it here because you will start from this point. You have now two lines, the facial midline and the horizontal line. And be careful with the gingival line if you can see it from the small perspective, from the small view, because this is important. This is a difficult case. You have to open your eyes. I can see everything about the gingiva, papilla, and so on with a smile, and usually that happened with a European lady or Egyptian lady around 18. A lot of them, by the way, when they smile, they can show about 0.5 to 1 millimeter of the gingiva, and you need just to focus on that. And it's important, you need to put in your plans. The most important one in the smile view with a smile arc, because you just arrange the incisal edge and the cusp tips based on that. The buccal corridor. Imagine if we have somebody with big buccal corridor and it's like a black hole between the cheek and his teeth that give him low attractiveness. It's unattractive. And if you look with someone with a very small buccal corridor, and you can feel the fullness of his smile and more attractive face. Incisal embrasures are important too, because if you don't have incisal embrasures, and when I was working in the luminaires, I had a lot of cases, they just give it to me with the minimal incisal embrasures and have to do it in the mouth. If I don't have a really incisal embrasures, that gives me the feeling of old age, it's like attrition, or in some cases you feel it like if the food is stagnant between his teeth. It's really unattractive, and you have to put in your mind to open the incisal embrasures and follow the symmetry. It's getting bigger when we go distally. From the smile to the macro, and the macro again you have a low 5 related to the gingiva and 5 related to the teeth. Gingival color and texture, gingival crest level, gingival zenith. Do you know all gingival zenith?
No.
Okay, gingival zenith is the highest point of the gingiva, and usually it's just distal to the midline. Give very lovely natural result on the finishing. Usually we put it with laser, with the finishing. It's lovely, especially with males, adults. Papilla and black holes, this is really important. Very important. It's the challenge for any implantologist and periodontologist, I guess. You need to check the papilla firmness, color, height, and you don't have any black holes. There is a special treatment and modalities for the black holes, so we have to put it in mind. So I see it first in the analysis, and then I put it in planning. The gingival height, and I know that I need the central incisor same height like the, sorry, go back. I need the central incisor same height like canine, but the lateral incisor crest is about 0.5 millimeters shorter than that level. As we've just said, in the incisal embrasures, gingival embrasures are important too for aesthetics, to give a space for the papilla, and it's very important for hygiene as well. So I need to care about smoothness and topography of it. Topography of it. This is important. This is very important. We have a lot of courses talking about this. Of course, with the proximal contact, it's getting smaller when we go posteriorly. So if it's 2 millimeters between the central incisors, 1.5 between central and lateral, we get it like around 1 millimeter between the lateral and canine. Well, a lot of people talking about proportions. Is the proportions are really important? It is important. Is it a holy thing that we need to follow just blindly? No, no, no. Changing a lot. So in the past we used to make golden proportions, and we see all the American kisses is exactly the same. It's the same smell, the same proportions. But the golden proportions doesn't put in mind the soft tissue dimensions and the bone dimensions. So we get what we called red proportions, recurring aesthetic dental proportions. Edward McLaren and Kochman 2014, 13 and 14, they follow this. They follow that. They don't follow golden proportions anymore. A lot of aesthetic dentists, they don't follow the golden proportions anymore, because you just take the dimension of the central incisor and you put all the relation dimensions just from an exact equation, and we're not the same. We're not have the same proportions, all of us. Dr. Muhammad was talking nicely about the relation between width and length. Usually for a female, I put it like 72% to 75%, 77%. For a male, I start from 75% to 80%. More than 80% can give a strong appearance or older age appearance. This is important. So golden proportion now from numbers from exact to range, but the symmetry doesn't have a range in it. So symmetry is important. We really need to make a perfect symmetry between the central incisors. Some clinicians like me, I like to make the symmetry, perfect symmetry between the laterals and canines too. And when I finish, I start to touch the angles and touch the surface to make them different, so the dimensions same, labial surface is the same, and then I make such characterization effect. Now they are using grids too, so they use this square to check the width and length, and they use small grid to put the same angle. It's like mirror imaging between them. You just mirror image them. The midline inclinations, like working with dentures, give a lovely natural appearance to it. And we're getting more medial inclination of the incisor edge and cusp tips as we go distally. From the macro to the micro, and in micro too, we're talking about color and shade. We have 5 in the colors, we have 5 in the shades, just to remember that. So when we start with the color, you really to be definite. I want to say, just inform the lab, but I want you to be definite first about the 5 of them. What's the dentine shade? What's the enamel shade? Translucency and transparency. Incisal edge effect, do you have a blue shade, a gray shade, amber shade? Do you have a halo white effect, a halo yellow effect on the incisal edge? Surface effects, do you have white patches? Which pattern? Horizontal lines? Smoked lines? Very smooth lines like the hypocalcification pattern? The analysis scheme gives you more information. Then you select in between it. You don't need every analysis point because your patient can have like 80% of it. It's going fine. This is important. Please stop giving your patient shakhbata ala waraq prescription. Please start to give your lab a photo colored to talk about color and white and black when you want to talk about shape and surface texture. Don't give your lab like a serialism of things شخبطة هو محتاج إنه يتخيل and you want to let him imagine to give you what you want. Make it clearer with a photo. Whether this is the photo of your patient or another photo, you want to make this pattern and this color for the patient. You write everything on the photo. Usually we explain all these things in our courses. This is to show between the transparency, translucency, and dentine and so on. Transparent means like glass, and you can see everything clearly behind. All the light pass through this, like this. But the translucency means musamfar. Is this musamfar? Can give you a gray effect. The translucency can give you a gray effect. So you need to check if the whole light passed through this point and you want to describe, or because a lot of labs say, is it transparent? Are you sure? You know why? Because if you will bet the transparency, you need to put a transparent dentine all over the journey to get the transparent effect at the end. But translucency can be easier. With the translucency enamel, you have shaded. It's shaded. You can put some colors in, but with transparency, you don't have color in it. With the shape and surface effect, you need white and black photo. You show what is the general outline. Is it triangular, rectangular, square? Where's the line angles, surface texture, embrasures, incisor and cervical? You need to describe anything about the incisal edge. If the incisal edge has mammallism, incisal edge is flat, incisal edge is curved. Dimensions and angulations. Again, white and black photo. And it's easy to do a colored photo to white black photo. Very easy, and you put your data on. Well, that's really important. So, what we just said is everywhere. Is in every magazine, every book. What we'll say now is not in every magazine, it's not in every book. This is the relations. Well, I invented the relations 6 years ago. And I was shy because I wasn't sure about if it's right or wrong and I needed to try it. And now we have a lot of papers now talking about the relation. Easy. I classified it to static relationships and dynamic relationships. There is no static relation on Earth. I just put it to myself to study certain situation with certain dimensions. So, the relation between the upper teeth and the upper lip in a relaxed situation. How can I get this? Can you imagine that? How can you get this? You tell the patient, please make Relax. And pause. That what happened. So I take this from the videos. I don't take this from photos. Same thing in relation between upper teeth and upper lip with a full smile. How do I know it's full smile? Again, I really want you to it's fantastic, the science, when we spend like 20 years telling the patient, would you please smile maximum E? Damn it, I put all the plans on this E. I just take it from the videos. I'll just show it to you now though. The lower lip with the upper teeth and smile arch. Smile arch is really important. It's very important to put the curve this natural. The 12 o'clock view, as Dr. Muhammad just said, we can know a lot of things from this 12 o'clock view. It's a little difficult when you take the photos, need some training, but I give you a lot of ideas about the curvature of the upper arch in relation to the outer curvature of the lower lip. Protrusion and retrusions. Midline. So it's really beneficial for orthodontists too. That what a lot of dentists miss. That was Dr. Just Muhammad talking about the age effect and age changes that happen on the lower lip. If you look at the lady on the left side, and you can see that her full smile doesn't show anything of the lower teeth. Have a look at the middle folio and just see like 1 to 2 millimeters. With the one on the right side, you see all the lower teeth, all of it, all the lower incisors. A case like this can be a very big problem to you in the clinic because you have models, you don't have photo, and you don't know that she show all her lower teeth when she talk, not smiling when she talk. So you really need to plan this right. If you want to whiten the upper, if you want to make a full arch at the upper, whatever you want to do on the upper, you have to consider the lower. If she doesn't want the treatment on the lower arch, you have to follow the color, dimensions, form, and so on the lower teeth. And one of my mistakes, I love to show my mistakes. And you can see this big effort with this case. Surgical crown lengthening, laser finishing, grafts, laser treatment of hyperpigmentation, mock-ups. And at the end, the upper teeth doesn't follow the lower lip. And the funny thing is, I didn't make anything for the lower anteriors. A big effort at the top. And I'm looking at, from the old school, just looking at the models, I'm talking with my patient about models. The fifth relation is the teeth relation. Is it just class 1 like this, normal, or we have malocclusion? Is it open bite like that and we can just finish it with laminates, like 2 or 3 sessions and that's it? Or is it a big case that need a maxillofacial surgeon, orthodontist, periodontologist, prosthodontist, mock-up and plan? Is the spaces there, is it easy and balanced and symmetrical? How can we know that? We need a photo. How can you know symmetrical or not? We need measurements. If asymmetric needs mock-up and is a big job, Asymmetrical spaces is a big job, it's not easy. Is it a class 3 malocclusion? What's the relations? Do we have spaces? What's the relation between upper and lower? What's the relation when she moves her teeth? Let's move to the dynamic relations, really interesting. I asked my assistant